Okay, let's start with chapter 23. I'm skipping a chapter, and it's okay. We only have an hour left. Topical drug delivery, oral rinses, and irrigation. There's two classifications of oral rinses, therapeutic and cosmetic. Most of the patients that go to Walmart and every place else to pick up their mouthwashes, it's considered a cosmetic oral rinse. But the addition of daily hygiene for plaque control, it might be recommended. It's an accessory to periodontal instrumentation. It's help for people with poor oral hygiene. After surgical procedures, there are pre-procedural rinses to help reduce aerosols that you're familiar with, as well as dental implant maintenance. And depending on your office that you work in, some will like other rinses or medicaments over other ones, and it's personal preference for what they see the patient can tolerate the best, as well as what they've seen works best. Now, the thing with rinses, though, it's only effective against supragingival bacteria. So if a patient's got 6 millimeter pockets, they can swish all they want, but it's not going to reach subgingivally. So healthy people may discontinue rinse if oral conditions can be maintained without their use. They can take care of the supragingival area. They don't need a mouth rinse. All right. Patients are going to ask you about that because the commercials are all brush, floss, swish. You know, that's the Listerine commercials. You're not done until you swish. Do they need it or do they not? They might want to use it as a prevention. You might want to incorporate something for dry mouth or something with fluoride into their oral hygiene routine. But you've got anti-plaque, anti-gingivitis agents, and they are meant to inhibit microbial colonization on a tooth surface and to prevent the formation of plaque or biofilm. It should eliminate or suppress the pathogenicity of existing plaque. So these anti-plaque, anti-gingivitis agents relies on two things: time, the time the agent stays in contact with the target site, as well as how well the agent gains access to the target site. So if the target site is 8 millimeters subgingivally, it might not be appropriate, but you need to have time. How long of a contact does it need in order to do its work? If you're just swishing for 30 seconds and then spitting out, and that contact is only 30 seconds and there's no substantivity, you're not going to be gaining any benefit from that particular agent. So you want something with substantivity, and substantivity is the ability of the drug to actually absorb or bind to intraoral structures like your teeth and your soft tissue, with subsequent release of that drug in its active form. So you want to find something that has a high substantivity. What is going to linger in the mouth longer? Okay, so we've got certain classifications of oral rinses: first generation and second generation. The first generation have antibacterial properties with low substantivity and have very limited therapeutic value in reducing plaque and gingivitis. And those typically are the over-the-counter preparations. Very low substantivity. Second generation rinses have antibacterial properties in addition to substantivity. So we have different things that are out on the market. One of them is a bisphenoid. All right, this is chlorhexidine. CHX is the abbreviation. My daughter's a nurse, and they use a different abbreviation for CHX. I don't know why, for chlorhexidine, but they use it also. That was one of the first surgical scrubs that was used. And back in the 70s and early 80s, when we were um, making our shift in knowledge of bacteria, if you can kill the bacteria, then underneath the gum tissue, then you're on a better track. Chlorhexidine was not approved in the United States at the time, so we were using chlorhexidine soap to actually irrigate and send the patient home with chlorhexidine soap to irrigate with. Sounds awful, but we were using the science from other countries saying this works. Now, guess what? It's standard care. But after rinsing, all right, with the chlorhexidine, it attracts and attaches to negative charged bacterial cell walls, causing lysis, which equals bacterial death. So what you need to know is the chemical, is it positive or negative? How does it work? All right. So it binds to the pellicle. This chemical binds with the pellicle, which inhibits plaque on the teeth. The substantivity, about 30% of the to oral tissues and plaque on the teeth. So it remains active for 8 to 12 hours after the patient uses the rinse. They swish for twice for 30 seconds with a certain amount, spit it out. That chemical is staying in their mouth for 8 to 12 hours, regardless of what they're eating or drinking. Slow release, high substantivity. We're using as pre-procedural mouth rinses. We're using Listerine as pre-procedural mouth rinses. This does contain alcohol. So whatever you're using for your pre-procedural mouth rinse, you want to make sure that the patient knows what it is. Because if they are not allowed to have certain ingredients either for health, medical, or religious reasons, then we want to stay away from things. Alcohol is usually an inactive ingredient that is in a lot of these things. So they contain alcohol. Non-alcoholic preparations are ideal for patients with dry mouth, mucositis, and people who are sensitive to alcohol. So even Listerine has a non-alcohol version. They're not as effective. But what they found with Listerine, we'll get into that. I'm not going to, that's a spoiler alert. Okay, indications for use for chlorhexidine before, during, or after periodontal debridement. It can improve wound healing. Patients can't necessarily brush right after they've had periodontal surgery. So they are given these little touffettes, the little pink or green sponges on a stick. They look like a lollipop. They dip that into the chlorhexidine and gently swab around the surgical area, okay, to kill the bacteria. And for implant control. The patient is to rinse twice a day, okay, because it works for 12 to 8 hours for 30 seconds. Now, again, this is what you need to know. Also, the positive ions of the chlorhexidine binds to the negatively charged molecules in the toothpaste. Okay, the two ingredients of negatively charged, you've got your fluorides and your sodium lauryl sulfate, the SLS, okay, and that can deactivate the chlorhexidine. So you want to advise the patient that it's best to rinse either 30 minutes before brushing or 30 minutes after brushing. And that can be problematic for some patients, trying to get that rinse in there. All right, but if they brush first and immediately rinse afterwards, which is what their natural inclination is, they are deactivating a lot of the chemical. But chlorhexidine is very effective in reducing plaque and scaling and root debridement, okay, versus just scaling and root planing alone. There are some adverse effects. It's generally very safe. The allergic reaction is very little. But one of the biggest complaints, especially with hygienists, is there is a yellowish or brownish extrinsic staining on the teeth, the tongue, and the restorations. especially cosmetic restorations, a yellowish brownish stain. The staining isn't permanent, but you have to scale it off. It does not polish off. It's almost like calculus. And it's most likely to be on the proximal surfaces of the lingual and the buccal, the proximal surfaces in between the teeth. It's hard to polish and scale in between the teeth really well when they're stained. There could also be temporarily impaired taste. Think about that chemical staying in your mouth for 8 to 12 hours. It's on your tongue. That tongue is where you're tasting. So if you've got a chemical binding to the tongue, you might have altered taste. The better the patient's oral hygiene is, the less staining they will have. Then we've got our phenolic compounds, and that's a Listerine, phenolic, okay? Essential oils. It's an alcohol vehicle. The mechanism of action is cell wall destruction, resulting in leakage of intracellular components and cell lysis. So you got to know that. The original Listerine was 26.9% alcohol, pretty high. This is why alcoholics will drink Listerine and other preparations. They're trying to get the alcohol in their system. This 26.9 has shown up on the boards. I have not heard from this group of students who have taken the boards whether it's shown up with them or not. But last year it showed up on for a couple students. These phenolics, though, have low substantivity. It's related to the duration of tooth contact. You're swishing and you're spitting out, and then you're done. There's not a lot of substantivity. But it has been shown to reduce plaque and gingivitis from 20 to 34%, which can be pretty substantial. The directions are they take 2/3 of a fluid ounce and swish it for 30 seconds twice a day. Some of them are very strongly flavored with their essential oils, and it's just nasty. That gold stuff was nasty. We used to tell the patients not to swish with Listerine because it contains so much alcohol if you had a dry mouth. But what they found is that even though there's alcohol in it, the essential oils that they have actually stimulate saliva. So new studies have shown that that's not necessarily the case. If you've got dry mouth, swishing with Listerine might help. Think about swishing with that. If you've ever needed to swish with that, because you just spit and then 30 seconds later you're spitting again and you're spitting again because you don't want to swallow it. So that is that's increasing your saliva. You have your quaternary ammonium compounds. Again, positive, negative charge. You've got your positive charged ions that are similar to the chlorhexidine, except after rinsing, they readily bind to the oral surfaces and are released more rapidly, and they lose their activity on the binding to the surface. So there's low substantivity. It does last for about 3 hours, though. There's also something called CPC, okay? Cetyl pyridium, okay, CPC, and that's the active ingredient in Scope, as well as Viadent Advanced Care. This CPC you'll see in a lot of mouthwash preparations. Rinse well. Wait 30 minutes again after brushing with the dentifrice. There might be some staining. There was staining with the Viadent because it was using a tree bark that was red or orange. Not so much staining anymore. Think about if it's killing bacteria and you're not removing the biofilm from the teeth, that biofilm that's killed is going to turn into calculus very readily. Ulcer, mucosal ulceration. Listerine scope, some of these can affect the tissue and create tissue sloughing. You have oxygenating agents, peroxides and perborates, okay, are used for the necrotizing periodontal diseases as well as pericoronitis. Hydrogen peroxide liberates gaseous oxygen. It provides a cleansing action for wounds. It bubbles, it bubbles, it bubbles, and it's directed at anaerobic microorganisms. So when we're trying to get things down to 8 millimeters that the patient can't reach, using an oxygenating agent can help carry that baking soda or carry that agent deeper. Very soothing for the peroxyl is very soothing. Glyoxide is very soothing, especially for canker sores. Exposure to less than 3% hydrogen peroxide has been found to be safe. When I was a student, hydrogen peroxide was thought to be continued use, a long-term carcinogen. We don't want to use it directly on wounds. But it's safe if it's diluted. But these are wintergreen or mint flavored, very safe. I would keep peroxyl in my operatory if the patient was really bleeding and clotting a lot, and you had all these black clots after you were doing your debridement procedures. I'd have them swish with some peroxyl, and it would loosen those up so they wouldn't have to go home and look at all those blood clots. There's povidone iodine, which has been around forever. Again, surgical scrub, antibacterial, antiseptic, and it's used in the prevention and treatment of surface infections. It's oftentimes in dentistry combined with hydrogen peroxide and used as a subgingival irrigant. You want to make sure that the patient is not allergic to iodine. This tastes awful, and it can stain clothing especially. So if you're using it in office, you want to be very careful with it, and you want your patient to be careful with it. This povidone iodine is wonderful. Wonderful. I would put it in my ultrasonic unit and irrigate with that as an irrigant, because I had a special tip that would, and a special bottle that I could irrigate with. Now, Therasol is an Oratec product. This is not. This has high substantivity without the staining. This is like a liquid toothpaste. Patients can brush with it as they can with the chlorhexidine. They can irrigate with it as they can with the chlorhexidine, but it doesn't stain. It's got a mint flavor. I've used Therasol for 35 years now, and have had very good results with it, and the patients like it. So if they like it, they're going to use it. Again, high substantivity. It doesn't stain. It does have PCP in it, but it's not the active ingredient. And it's a local company. Certain fluorides have been found to be help with the bacteria in the mouth, not only for sensitivity and remineralization, but to inhibit bacteria. So stannous fluoride exhibits antimicrobial properties in the control of gingival inflammation and bacterial repopulation. So stannous fluoride is the fluoride of choice if you're trying to control gingivitis or inflammation. Crest Pro Health, Parodontics, GSC has one. This is the GSC product. The Pro Health and Pro Enamel, I believe, also has the stannous fluoride. Omni also has liquid preparations where the patient would do a pump and then put some water in and swish with this. You can also irrigate with stannous fluoride. But stannous fluoride has a tin molecule in it, and that prevents bacterial adhesion That tin molecule is great for dental hypersensitivity. However, extrinsic staining can occur with extended use. So if you've got a patient with composites that are on the anterior areas, it wouldn't be the drug of choice, so to speak, but it's great for bactericidal, it's great for caries control, it's great for dental hypersensitivity. So they all, fluorides are good for a lot of things, but stannous is good for everything. So now the toothpaste, the Crest as well as the periodontics have added copolymers into their product to prevent the staining. Sodium fluoride is great for caries prevention, but it really hasn't had any science behind it for anti-gingivitis action and anti-plaque. Pre-brushing rinses have surfactants in it, sodium lauryl sulfate, which acts as a detergent, and it makes the teeth slick. It's indicated to be used before brushing. Some patients swear by this, and it's hard to find now. You have to go on Amazon to find plaques because it really hasn't been shown to have any real benefit to it. It's similar to using mouthwash. Okay, sodium lauryl sulfate is what makes everything bubble in our soaps and detergents. Alcohol-free mouth rinses. Most of our mouth rinses do contain alcohol. Some fluoride preparations don't have alcohol in them for children's use. Some of the other adult preparations don't have alcohol in them to help with the dry mouth. So you want to customize what you're recommending for your patients. There's all sorts of alcohol-free products out there. BreathRx is very popular. Yep. Is BreathRx, does anybody know if that is available at the stores, or do they have to get it through their dental office? Okay, Biotine, we don't right now, but we oftentimes have samples of Biotine for patients with dry mouth. Now, alcohol-free rinses. Pregnant women aren't supposed to have any alcohol. Recovering alcoholics, okay, they're always in recovery. Patients taking medication that could additionally dry out the mouth. And most medications dry out the mouth. Patients taking metronidazole, right, needs to avoid alcohol preparations because whatever's left in the mouth, the patient will swallow, and they can get ill from it. They can have a reaction. Antabuse, which is something that alcoholics will take when they're trying to avoid alcohol. Antabuse is something, if they drink alcohol, they'll just be vomiting all over them. And metronidazole acts similarly to that. So there's some precautions. Oral irrigation was very popular in the 60s as an adjunct to brushing and flossing. Studies show a reduction in supragingival plaque in gingivitis patients. Supragingival, and we know what happens on top of the gum, has a direct effect underneath the gum tissue. It's great for patients with ortho, patients living with diabetes. It massages and stimulates the gum tissue. It lavages underneath the tissue. And there's all sorts of oral irrigators out of there, and shower flossers as well. Research shows a significant reduction in gingival bleeding, inflammation, probing pocket depths, both supra and subgingival biofilm, as well as inflammatory mediators that are instrumental in bone resorption. So this is a pickpocket here that is attached to a water pick or a water jet device. It looks like a little rubber tip stimulator, and it's got a tiny little hole in here. So if you put something in the water reservoir, you can actually get a medicament underneath the gum tissue this way. This is what I would send patients home with. I would send them home with a metal cannula and an oral irrigator here, usually an endo syringe, so they could put whatever medicament we were recommending for them in here, and they could place this underneath the gum tissue. And it takes a little bit of education for the patient, but boy, is that better to use. We have these huge syringes, monojet syringes with this huge cannula. We're just fooling ourselves when we think we're irrigating. Oral irrigation, 1 to 2 millimeters subgingival. Okay, for the pickpocket, look at this for substantivity. 5 seconds. You need to be in there. You're not just zhooing it around. You need to be in there to allow that water jet to do its thing. Over 7 millimeters in pocket depth, you're only reaching about 64% down. 43.4% of the clinicians perform chairside subgingival irrigation. Science has shown us that what we do chairside, our one-time irrigation has no effect on resolution of healing, no effect at all. But we can irrigate chairside and then send the patient home with what we're irrigating with. That is what's going to make a difference. So just because we irrigate chairside and offices are charging for this, science is showing it's not doing any benefit for the patient. Now, cosmetically and intellectually, we're saying, well, we're helping to flush out, and we just, let's just, it makes sense to us, but the science is not bearing out that. So, know the term hydrokinetic activity, okay? That is when a power driven, okay? It's either the main outlet or a battery, okay? You have a pulsing stream of water or a medicament, and you want it to be pulsing. You don't want a constant stream. And there's two zones that you need to know about, the impact zone and the flushing zone. This is something that I recently added last year because this was on the boards. Impact zone and flushing zone. Impact zone is when the irritant comes in contact with the tooth surface. The flushing zone is deflection of the irritant subgingivally and interdentally. So you've got a flushing zone, okay, goes deeper than the impact zone. So an impact zone, the irrigant makes initial contact. The flushing zone, the irrigant is deflected. And then you've got your lavage where the irrigant is in that subgingival region and then coming back out again. And that's where you want the pulse. Okay, pulse, 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 pulse. It's going to get much farther underneath the gum tissue. It's a good way to get medicaments underneath the gum tissue, lavage out. If we can get rid of COVID, I will have the Waterpick people come in and they feed you Panera. They come in with very good food, and they can give you a lunch and learn on the benefits of Waterpick and their various toothbrushes. I would use a Viadent in private practice because it warmed, the reservoir warmed, and you could actually put a metal cannula on, and it was just lovely. And this is the ViaJet here that patients can purchase. You want to make sure that the patient's using it to start with on a low pressure. Their mouth needs to be over a tooth, over the sink, because the water's got to come out someplace. And they want, you're supposed to direct it at right angles to the tooth surface and not angle it subgingivally unless you are using a subgingival tip for it. So Waterpick has nice brushes that you can add as well for special needs. It almost looks like a little end tuft brush with water coming out here and then a little brush. It's great for cleaning around ortho and around implants. Plaque seeker, okay, little brushes. Oral-B has brush tips similar to this too, but they don't have the water jet device. So patients with severe chronic periodontitis and refractory periodontitis may require more aggressive treatment and referral to a periodontist. If you're working for a periodontist, you're already getting that patient. So you need to be aware of what is out there and the pros and cons. You need to be on the same page with the other hygienists in the office, so you're all recommending things the same, as well as the doctor needs to buy into it as well. All right, should you recommend an oral irrigator to a patient who has periodontal abscess? Oh, wait a minute. Okay, no, no, no. And that is right, because you don't want to press that and force that bacteria or whatever's caught underneath the gum tissue farther down. Which of the following substances can cause extrinsic tooth stain? Now, chlorhexidine isn't. Chlorhexidine we've talked about. Phenols, alcohol, CPC. Topical antimicrobial agents delivered by a rinse are effective against supragingival bacteria. True or false? They are effective for subgingival bacteria. Oh, topical antimicrobial agents delivered by a rinse are effective only against supragingival. I apologize. They don't reach subgingivally. What do you want? Low substantivity or high substantivity when you're treating somebody? High substantivity. Which is a phenolic compound? Stream. Pulsating stream of water in an oral irrigant is better than a steady stream of water. True. Is it advisable to brush your teeth right after rinsing with chlorhexidine? Okay, and the other reason we don't want them brushing right after chlorhexidine is it tastes awful. So they put there's flavoring agents in the chlorhexidine. If they brush right afterwards, they have then brushed out the flavoring agent, and what's left in their mouth is that chemical taste. So we don't want them rinsing or brushing right after the use of chlorhexidine, because it takes that flavoring agent out. Which one is sold without a prescription? First generation. Which rinse has the highest alcohol content? Now this one should say Listerine Original, because they even make low alcohol. Biotine can make alcohol free. Rembrandt can make alcohol free. Listermint, I don't even know if that's still around. Listerine is notorious, the Listerine Original, 26.9%. Caution must be used when using a handheld syringe in office for in-office irrigation. Okay, true or false? This is because pressure cannot be controlled and can cause damage. Ooh, I didn't talk about that. True, true. You want to be very careful when you're squirting, especially after instrumentation. Oh my gosh. Okay, that's it. And I've run out of time. So I will post number 22. I will post chapter 22. And I'm making a note. Are there any questions?
Misty, I had a question.
Yeah.
For medical compromised patients, I just wanted to run it through really quickly because I haven't had them before. So